Kind of good. As you're gonna learn everything and deal with it.
Good morning, everybody.
I definitely.
Tristan Stevens.
Joined the meeting.
you. The truth is that because there's no cardiology residents here, the void is petition.
So good morning, everybody. I'm sorry if we have our guests. We have both new cardiologists in the room, Dr. Mark Henson, and today's guest is Dr. Akram Mikaeilpour, who we're hoping will join us next year. So it's a little bit different for rounds than usual. We actually have them in the room, which we didn't have last year, and on Zoom. So we have over 21 people joining, and many of you I know are in groups and rooms in various places in the province. To introduce Akram, Akram is a graduate from Iran in cardiology in 2010 or 11, I believe. She worked in practice for many years, 7 or 8 years before coming to Canada and doing a adult congenital clinical cardiology fellowship, and now doing ambulatory cardiology at the Women's College in Toronto. So I've really asked her to talk to us this morning and really sort of give her thoughts on the role of sort of advanced cardiology in that setting. And with that, she's going to talk to us today on adult congenital heart disease and sort of high-risk pregnancy and how can that fit in sort of the New Brunswick environment. So just 1 second, I'm going to go back to Zoom if I can get back to it. Zoom. And share my screen. We're recording already. Whoops, share. All right. And there you go, Akram. So you can join here. You probably can just go like this. And let me just minimize this. It'll be easier for you. Maybe not. There we go. All right. Thank you.
Thank you, Dr. Legario, for your kind introduction, and thank you all for joining me today. I have no disclosures, and today I'm gonna talk about the current burden of adult congenital heart disease and its changes over the last decades. Also, what are the available care resources for this population now in North America? Then I'll briefly introduce the ACHD program in Toronto, where I had my training in. And I'll be talking a bit about why we are hoping to have an ACHD program in New Brunswick and how a high-risk pregnancy clinic can help young women with cardiac disease here. The first question to answer is, why do we need an ACHD program? Well, every day around the world, there are some children are born with some kind of congenital heart disease. So what happens to them after their birth? This graph is trying to show what happened in the past, what the current situation is, and what we are expecting in the future. The light blue part at the bottom is indicating the number of children with congenital heart disease. As you see in the past, they barely could survive to their childhood. And at 80s and 90s, because of the procedures and surgeries that invented, they could survive to their adulthood as well. So the dark blue part in the bars, they show the number of adult patients with congenital heart disease. As you see, it's obvious that this population is growing and it continue to grow in the future. This graph is created based on the data in the past and estimates the situation in the future. but the numbers that you are seeing here is real numbers. The data, this data is from US. And since 1970 until the year 2020, the number of adult patients that have congenital heart disease is significantly increasing. They could show 5% increase in numbers every year. So now we know that there is a specific population called ACHD patients out there, but let's see how they are doing now. This article is recently published in March. The data is from Sweden. They tried to compare the adult patients with congenital heart disease in terms of survival rate with the matched groups in general population. So they showed that the mortality rate in adult patients with congenital heart disease is 3 times more than matched groups in general population. It seems that there are some room to improve their survival. But please keep in mind that the patients who enrolled in this study, they were already under care in ACHD programs. They even do worse if they are not under regular care. So the blue line here indicates the survival for the patients, the ACHD patients, that they had never been referred to an ACHD center. You see that there's a significant decrease in survival rate for those patients compared to the similar patients that they are under regular care. Okay, it seems that ACHD program is not a bad thing to have and it could be beneficial, but do we need it in New Brunswick? Dr. Roy in 1994, he studied the prevalence of congenital heart disease in Nova Scotia, New Brunswick, and PEI. And they could confirm that the prevalence is around 1% per live births. It's very close to what we know now, and it's understandable that it remained stable. But what is important about this study is their study population were the people that born between 1966 and 1989. So these people right now, they are in their 30s and 50s, and they are exactly the population that we are talking about. So having this information, I did a bit of math. The annual live birth rate in New Brunswick is around 6,500 every year. So the estimation is every year we have around 52 children born with some kind of congenital heart disease. Something between 80–90% of these children, they could survive into their adulthood. So it will be something around 40 people every year. And considering their 80% survival rate, again, the estimation is we should have some adult patients, around 1,000 people with congenital heart disease, that they are already between their 18 and 50 year. So Dr. Webb and Dr. Oxlin published this study in 2015. This is a review article about the care of ACHD patients around the world. And in this review article, they suggested that at least one ACHD center is required for a population of 2 million adults. So based on this calculation, we need at least 17 centers in Canada. And the current available centers in Canada are around 16 centers, considering the Nova Scotia and Newfoundland, that they're our very kind pediatric cardiologist colleagues. They are looking after the ACHD patients as well. And the numbers in US is almost similar. I don't have the data, similar data for Canada. This is for US, but as you see, still there's a huge need for ACHD centers. around the world and US. The states that colored in red, they need at least 6 centers, 6 new centers. But on the other hand, until the year 2021, there were less than 500 people who were officially trained in ACHD fellowships. So it seems that there's a significant imbalance between disease burden and the care resources that we have. Let's talk a bit about this population, just very briefly. Based on the diagnosis that they have, they're divided into 3 different categories. The first one is the patients with just simple congenital heart disease, for example, isolated ASD, VSD, or they could have moderately complex congenital heart disease. And a good example of this group is Epstein anomaly or tetralogy of Fallot. And the last group is the patients with highly complex congenital heart disease, for example, CCTGA, LTGA, AVSD, or hypoplastic left heart syndrome. I'm going to give you an example for moderately complex congenital heart disease. As I said, tetralogy of Fallot is a good example. You see here, let me show you. Here, there's a huge VSD, overriding of aorta, small pulmonary artery, and some subvalvular stenosis and a bit of RVH. So these people usually need some intervention in their early life, and usually after procedure, they do well and with acceptable quality of life. You might have seen these patients some point in your practice, but as you know, because of baseline abnormalities and in some degree because of the procedures that they've done, they are very vulnerable to develop heart failure, some kind of arrhythmias, and complications related to pulmonary valve. So that's why they need to be under regular care to make sure that we can address their problems when it happens. This is another example of a highly complex congenital heart disease. As you see, this patient born with only 1 functional ventricle. The left ventricle here and aorta are very small and not functional at all. So if you don't do any intervention for these patients, they won't survive, and they need some stage interventions in very early life. But what they will have at the end is having a left circulation with the only pumping chamber, only ventricle that they have, and the right circulation, there's no pumping chamber there, and the IVC and SVC is directly connected to the pulmonary artery. This is what we call Fontan circulation. It's obvious that there's a unique anatomy and unique physiology here, and these patients will have unique complications as well. And these are the patients that should be under sometimes very close follow-up under specialized ACHD care. So I'm going to talk a bit about the ACHD program in Toronto. This is Dr. Webb. Unfortunately, he passed away about 2 years ago. He established the first ACHD clinic in Toronto about 60 years ago, and it happened around the same time in Britain and US as well. What we are doing now is usually the patients are under care in sick kids hospital around until they are 17. And in some point between 17 and 19, they transfer to ACHD clinic. This is Dr. Alonso, the current program director. He's very supportive of colleagues and patients. One of the important outcomes of ACHD program in Toronto is what we do in ACHD clinics. And it is the providing regular follow-up for adult patients with any kind of congenital heart disease. Obviously, they are very vulnerable to develop arrhythmias, different kinds, and in earlier stages. And based on what they need, we offer them cardioversion, ablation, device implantation, or medical treatment if they need. Dr. Oxlin established the orthopathy clinic and also the Hearts and Minds clinic, which is kind of special for people who have congenital heart disease plus some kind of developmental delay. And Dr. Granton is a huge part of our PH clinic there. One of the challenges in ACHD care is related to heart failure. Most of the patients in congenital heart disease, especially if they have complex lesions, they will end up with some kind of heart failure at some point in their lives. And again, mostly they will need heart transplant at some point. It's very important for them to be under regular follow-up, so we can do the transplant assessment at proper time. Sadly, sometimes they are not eligible for heart transplant because it's too late and they already have some complications and high surgical mortality rate. I won't go through the details here, but surgical and interventional team, they are very supportive and they are doing procedures for congenital heart disease. We rarely have unrepaired like ASD, ABSD, sometimes tetralogy of Fallot or CCTG among our patients, but most of the time the procedures are just a repair of complications. So as a summary, ACHD program in Toronto now is acting like as a ACHD tertiary center. We have anesthesiologists who are expert in congenital heart disease, surgeons, and EP team, and even ACHD imaging specialists, because they know neonormals and unique anatomies, unique physiology changes in the complex congenital heart disease. I'm gonna talk a few words about high-risk pregnancy clinic now. What does it have to offer? Again, one of the challenges in women with congenital heart disease is unplanned pregnancies, especially in younger women. What we need to do is to give them proper information in proper time about contraception. I would just very briefly say that in simple lesions, if they are repaired, usually all options are safe to use. In moderately complex lesions, again, if they are repaired and there's no complications, most of the options are safe to use. But for complex lesions, they should be assessed individually. And during the visits, we discuss the benefits and risks. But again, there are some options that they can use safely, but with some considerations. When we are talking about congenital heart disease, women, and pregnancy, the first thing that we might think of is they might have some contraindications for a pregnancy. But having specialized pregnancy clinics, now what we do is we give information about the risks, and then patients, based on their cultural or religious background, they decide what to do. We don't use the term of contraindication for pregnancy anymore. And during the counseling, we talk about the risks that can be maternal or fetal risks. They can be cardiac related or OB related. They can be short-term or long-term. For example, some patients could survive the pregnancy and they can have babies, but unfortunately they are not around long enough to take care of their babies, and they should know about this information. The babies have their special risks. Some of them is because of mother's serious illness. They could have very serious heart failures during pregnancy, and they have higher risk of premature labor or having similar congenital heart disease or another kind of that. And we also offer cardiovascular care during pregnancy, and we can provide delivery plan to OB team to make sure that patients are safe from cardiac standpoint. And if the patients need, definitely we offer post-delivery cardiovascular care until 6 weeks after delivery, and longer if they need. So we talked about the recurrence risk of congenital heart disease to next generation. It is overall, the risk is overall something between 4 and 6%, but the good example of this is Marfan syndrome. If father or mother have Marfan syndrome, the risk of having mutation in baby is 50%. In this case, we usually recommend IVF to make sure that the baby won't get the mutation. So as a summary, we know that the burden of ACHD has been increasing during last decades, and we expect that it will continue to grow. We know that the survival rate for children with congenital heart disease is better now, but still there are some room to improve the survival rate in their adulthood. And some of them need lifelong, regular, specialized care. An ACHD program works best if the whole team is contributing. It's not just ACHD cardiologist. And pre-pregnancy counseling can help young women with congenital heart disease or any kind of cardiac disease to make an informed decision by understanding the risks during counseling. Thank you so much for listening. This is my email address, and I'd be glad to hear from you. I'm happy to take if there are any questions.
Great. Thank you. All right, so I've opened the floor for everybody. If there's any questions on the outside audience. Thank you, Sue. I do have a question. I guess in my mind, there's the goal or the way to imagine this is how do we articulate best the unmet need to the people out there? Because I'm sure, as you suggest, there are lots of patients with these problems and these conditions. Likely, many of the cardiologists in the province have a handful of these patients in their practice. Sometimes they don't know what to do with them, and they refer to Halifax, or they call a colleague, they ask for help. So how do we articulate best the unmet need, and how to really at the same time articulate the benefit to patients and to the clinicians that take care of these patients already, that someone with some expertise can actually help manage this and improve ultimately the outcome for these patients, because ultimately that's what we're trying to do. So, I mean, these are complex questions. It's easy to think in theory, but how do we articulate that and make it happen? What are your thoughts?
I would say it is very hard work, and it's going to take a lot of efforts and time. I don't expect that's going to be easy. And as an example, actually, I was listening to one of my colleagues that is ACHD specialist in US, and she around, I guess, 1 year ago, she started the ACHD program there, and she had a talk recently, I guess, in last 2 weeks, that what were the challenges and how she could do that. Yeah, it seems difficult, but I think we need to spread the message. We need to educate our patients that they would benefit, they would have better outcome and better survival rate being under this, under care in ACHD program, in a specialized program. And and also our the members of healthcare providers, not just cardiologists, the family physicians, GIM patients, GIM colleagues. So they know that there are some, specific programs that they can look after these patients and follow up them regularly. This is what I can say for now, but I probably need more information when I start and see how's the population here, and then maybe that time can program a bit better and have a better plan to start.
Yeah, I would agree with you. I think what you said was right, is education. So obviously rounds like this are helpful, but it's education at every level. And my sense is being available, people understanding that you're available, and that's an easy thing to say, but availability means on so many levels that people can contact you, and then you build partnership. And those partnership is really, you're not necessarily trying to take over patients, you're really trying to provide help and advice and expertise to help manage patients. I think so if we follow those kinds of things, I think we can build something much bigger in the province that will be very helpful to the population of New Brunswick. And then the administrative challenges around that then are much easier to sort of articulate also with the taxpayers and the administrative types to try to build something. Any questions from the audience? Any thoughts? This is obviously something a little more specialized and some things that often we have questions about. I see myself on the surgical side, congenital heart disease or adult congenital patient. The biggest challenge I have is not recognizing the problems, is honestly, what are the triggers for intervening or not intervening, which these are patient populations that I don't normally see. I don't really understand what is typical for that kind of patients, and when is it too late, when is it too early. I have a couple of patients in their 70s I follow with complex Epstein, for example. Like, I'm flabbergasted of, they were missed for many years of their lives, and now you see them and they're like, holy moly, like these giant hearts, and they've been asymptomatic all their lives, but now they're entering the late part of their lives and they've missed opportunities all the way along, and now you sort of what do you do? Anyways, so these are the challenges I've obviously asked for help elsewhere to help me, but all I could say when I first saw them, and I recognized that there was something really weird here. This was not normal. This does not look normal. We missed something here.
Yeah,
Anyways.
exactly. It took me 6 months at my fellowship to learn the anatomy first and the physiology, and then think about how we need to manage these patients.
Yes.
That's right.
Yeah, I just add a comment that adult congenital heart disease, as you pointed out, is not as rare as we might think. And with advances in prevention and better recognition diagnosis, the burden of this condition starts to be better recognized. And I'd underscore the opportunity of an expert like yourself in drawing together other disciplines, whether it's obstetrical medicine, internal medicine, neonatal care, cardiac imaging, MRI, echo, advanced echo, CT, and kind of integrative team. And in order to have all parts of that team functioning at the best capacity, you need to have kind of leadership and a sense of expertise. And as a clinical cardiologist, I can only speak for myself, but none of us feel particularly, I certainly don't feel particularly comfortable dealing with adult congenital heart disease, despite having some experience in the same centers that you trained. So it's an incredible opportunity, and I think would make a big impact on the population of New Brunswick.
Okay. So with this, if there's no other questions, I'm going to close rounds for today. Thank you for joining us, and we'll see you next week. Thank you.